So welcome to Math 119-312. Today we're going to be hearing about the effects of policies on COVID-19.
All right, thank you. Welcome everyone to our presentation. So our group's topic today is on the effects of policies, COVID-19. What we hope for our audience to get out of the presentation today is a better understanding of what policies have worked, what policies have not worked, and the consequences of policies in each scenario. Next slide, please. So the big questions that we're going to grapple with today are: how do we evaluate the effectiveness of policies? What healthcare metrics do we care about in evaluating these policies? And then what social well-being metrics do we care about in evaluating these policies? Next slide, please. In order to answer our first big question, we first need to take a closer look at the metrics that we should be looking for in healthcare. We start with a few rates that'll tell us more about the bigger story. First, we need to know what percentage of the population is being tested. Obviously, if a significant portion of a state or country's population is not getting tested, then it will be difficult to accurately determine how much a certain policy is affecting the spread of COVID.
Next,
take a look at the positivity rate for a certain population. Now, the term positivity rate can come across as a little misleading, but the definition generally is the percentage of people who test positive for the virus of those overall who have been tested. Again, this is highly dependent on the percentage of the population actually being tested, but if a significant portion of the population is being tested, we can then rely on the positivity rate to accurately reflect how well a country or state is containing the virus. After that, we can take a look at the hospitalization rate. This rate primarily pertains to those that are older or immunocompromised, but this statistic is not any less important since it applies to a smaller portion of the population. It's incredibly important to keep note of the hospitalization rate because it details the cases that are seriously life-threatening and also gives an idea of how many hospital beds are being occupied by coronavirus patients, which is helpful to make sure that hospitals are adequately prepared for any immediate needs for hospital beds. Hospitalization rate is a smaller but theoretically proportional rate to the positivity rate, which then helps each rate gain validation. Finally, the two major metrics that we should be always keeping an eye on are deaths and the death rate from COVID. Obviously, these are the most significant metrics, but focusing on lowering other rates will lower death and death rates. So if a policy is focused on reducing the positivity rate and is successful, the lower positivity rate would then theoretically lower the death rate if the two rates are proportional. Next slide, please. Now, the campaign that almost all of you, if probably definitely all of you, have heard is flattening the curve. And the point of this campaign is to demonstrate how catastrophic it would be if the number of people infected were above the healthcare capacity, presumably from a lack of precautions. But with precautions and social distancing, the population could then flatten the curve and stay within the healthcare capacity that's critical to patient recovery. The curve itself is, back to that slide. The curve itself is a representation of the metrics that I touched on in the last slide. It's just the positive cases at a given moment in time, which is then a function of the positivity rate. And then within the curve, a notable subsection is the amount of hospitalized patients at a given time, which is obviously a function of the hospitalization rate. Presumably, as long as the amount of positive cases at one time never exceeds the capacity of the healthcare system, then the healthcare system would be able to do everything in its power to treat patients with the coronavirus. Next slide, please. So the last statistic I'll talk about in regards to the healthcare system is the availability of PPE. So PPE, or stands for personal protective equipment, in regards to COVID is just a reference to the equipment that healthcare personnel should be wearing to treat patients with COVID. This includes items like surgical masks, N95 masks, goggles, gowns, or gloves. The important statistic that comes from this definition is the availability of PPE to healthcare personnel. In an ideal situation, there's enough PPE that every healthcare worker is fully equipped and clothed to treat a COVID patient. In order to increase the likelihood of this scenario, the CDC has recommended conservation strategies for use by healthcare organizations and personnel intended to assist healthcare organizations in determining conservation procedures during this time period. Next slide, please. Now,
I'm going
I'll
to get some.
pass it off to Nick to discuss the social well-being metrics.
Great, thanks, Tommy. So in evaluating these policies, we must look at whether the policy is reasonable enough by focusing on some social well-being metrics. As in, like, do these shutdown orders so largely negatively impact social well-being outcomes that they are not worth it? So for a policy to be effective, it must maximize the trade-off between saving lives and social well-being outcomes. So the question we must ask becomes, how badly does a policy affect certain economic or social well-being outcomes? And if the policy were not implemented, how badly would that same place have been affected by the virus without the policy? So as we've discussed in some previous classes, metrics such as unemployment, GDP, stock market returns, inflation, and price stability may be important to keep in mind when evaluating some external effects of policies. So now let us take a look at a larger scale example of the trade-offs at hand on a country level. So in this graph, we plot confirmed deaths per million on the y-axis versus GDP growth in Q2 for quarter over quarter for that same country. What this graph is trying to determine is, do certain policies that cause GDP to increase or decrease significantly predict differentiated health outcomes, i.e. more or less deaths per million? As you can see in the country studies, looking at policies that eliminated, so there's not just appear to be any strong relationship between the two. So what this means is that if you were looking at policies that eliminated large amounts of GDP for certain countries and less for others, these policies had a random effect on the amount of deaths per million. Like take the US and Japan. They had similar GDP scalebacks, but very different deaths per million, meaning there's other factors like PPE and shutdown policies that can help explain this difference between the two in terms of health outcomes. Yes, there are flaws to these measures, but this graph sets the stage for the idea that when looking at the effectiveness of policies, you must focus on the trade-off between healthcare measures and social well-being outcomes. So a potential takeaway from this is that having more aggressive healthcare policies that limit deaths does not seem to impact GDP performance. So now for another graph that looks at state level data. In this one, I plotted state data for cases per million by state on the y-axis and change in year-over-year unemployment by state as of September on the x-axis. So for example, we took Wisconsin's change in employment from last year to this year versus their cases per million at that time in September. What you see in this is there's some sort of negative relationship between the two. This implies that states that have more cases are those that have less unemployment. However, the directionality of this relationship seems uncertain. But if you look at it in terms of policies, it seems that those states that kept jobs for individuals by reopening quicker or not shutting down as aggressively had more cases as a result. So it seems that on the state level, policies that affected unemployment had impacts on the spread of the disease and certain health outcomes. However, the next, maybe more important question becomes, is that incremental decrease in cases you get from larger unemployment worth it? Or, on the flip side, is the limiting in cases as a result of policies that cause large unemployment worth it? Again, there are many other variables impacting this graph, but it plants the seed for how we should evaluate policies, namely looking at the trade-offs of outcomes in cases when they were not implemented. I will now pass it off for a more in-depth look at specific policy differences and analysis of the outcomes that followed.
So when looking at policies, broad categories of policies and their impacts, it's important to look at lockdowns, of course, because they have a large impact on everyday life. So lockdowns are basically a category of restrictions that include stay-at-home orders, closure of schools and non-essential businesses, and broad travel restrictions. So lockdowns essentially are an overall reduction of movement within and between areas. And lockdowns can have a widely varied implementation in terms of what restrictions are actually put in place and the enforcement of these restrictions. And lockdowns can fall into two categories. That would be localized or targeted lockdowns versus broad lockdowns. So localized lockdowns can often have a smaller economic impact because they cover a smaller area, but the effectiveness of these lockdowns can be less than a broad lockdown, especially if there's not travel restrictions within and out of the localized area. Because if people are traveling in and out of a place that is locked down, it kind of mitigates the effects of the lockdown. And lockdowns of COVID policies generally have the largest economic impact of non-pharmaceutical interventions. And so lockdowns are often implemented when cases have gotten to the point where other policies, other NPIs, such as testing and contact tracing, either there's not enough capacity or they've been sort of overrun. Because these are sort of, lockdowns are kind of a broad brush restriction. And so we're gonna look at 3 different case studies of different countries and how they implemented lockdowns: China, the United States, and Italy. And these 3 countries vary greatly in how they implemented the lockdowns, and then of course their effects of these lockdowns. So China, they had probably the strictest lockdown of any country, and of the 3 that we're going to look at. Their quarantine was announced for the province for Wuhan city on January 23rd, and then it was expanded to the rest of the province of Hubei shortly after. In this case, public transportation was suspended, large gatherings were canceled, especially the Lunar New Year celebrations, which were occurring right around that time. And there was effectively a stay-at-home order. There were also restrictions on travel where people, there was not a lot of leaving and coming into the area. The only leaving the area would be foreigners who had chartered flights from their country of origin. So it was highly restricted in who could come in and out of those areas. And then, of course, businesses were closed. And then oftentimes food and medical supplies were distributed to homes because there was a restriction on the number of household members who could leave per day or per week. This varied by specific region, but often it would be like only one household member could leave the house per week to go get food or medical supplies. And the lockdown ended up lasting around 10 weeks. And so this is just the timeline. You can see the first cluster of cases was reported in end of December, and the lockdowns began on the 23rd of January, and soon after were expanded to the rest of the province. And then, so here we can see the curve in China immediately following the lockdowns, or through that time period. And since COVID has an incubation period, you can't necessarily see the effects of the lockdown until a couple weeks after it was implemented. So you can see here where the lockdown began on January 23rd, and you can see a reduction in cases starting about 2 weeks later, which corresponds to the implementation of the lockdown, and suggests that there is an association between the lockdown being implemented and the curve being flattened. Then in terms of, in addition to flattening the curve, the lockdown, of course, has an impact on the economy. And so when we're looking at year-over-year growth, GDP growth for China, you can see in the beginning of 2020, there was a big dip, presumably based on the lockdowns. But since the lockdowns were so successful in reducing cases and controlling the spread of the virus, since the country has been able to reopen and go back to a semblance of normalcy, there has been a big recovery and almost to pre-pandemic levels of GDP growth. And so overall, China has had 86,000 cases, reported cases, and so that's 63 per million people. 4,600 reported deaths, which is 3.4 per 1 million people. And in the past 2 weeks, there have only been around 22 cases, which suggests that the lockdowns or the policies implemented by China to mitigate the spread of the virus have had long-term effectiveness and did a good job of really controlling the spread of the virus. So yeah, again, the lockdown measures appear to have been successful in controlling the spread of COVID-19. But of course, there were other policies in place, not just a lockdown, so you can't really isolate the impact. But still, models suggest that the lockdown was implemented later than what would have been ideal. So if it had been implemented only a week earlier, there could have been 67% fewer cases. And if it were implemented 3 weeks earlier, there could have been 95% fewer cases. And this is a common theme we'll see going forward, that lockdowns are generally implemented too late to be, or too later than they ideally should have been. And so now we'll look at Italy, which it had probably the strictest lockdown measures at the beginning of the pandemic, aside from China. So it started out with several municipalities in Lombardy and Veneto were placed under quarantine around the 21st, 22nd of February, and that was expanded to much of northern Italy March 8th, and then to the entire country a day later. So there was limited travel in or out of affected regions. This was a little less strict than China, where foreigners and people traveling in Italy were able to leave without as much headache as those traveling in China at the time of their lockdown. And again,
can I ask a quick question, just in terms of how they were able to monitor that these, that travel bans or that these gatherings were kind of enforced, whether that was in China or Italy, like how they kind of went about making sure that it was actually followed?
Yeah, so in China, there was strict enforcement of these measures. There were like legal implications for people who didn't follow them. In Italy, there were still some fines and again, legal implications for not abiding by these, but it was enforced not quite as much as China was. And then we'll see in the United States where there was very little enforcement of these policies. So, and then further, so Italy, the lockdown sort of started gradually, where only like large gatherings and like entertainment venues and sporting events were closed at first, and then that gradually shifted towards just all non-essential businesses. And the lockdown lasted until around May 3rd. And so again, we can look at the timeline of when it reported its first case to when the lockdown started of just the narrow areas, and then how long it took for that to expand to the whole country. And then again, we can look at the curve of Italy, and so the scale, since this is a very emblematic of testing capabilities, where it appears that cases are higher recently than in this initial wave, but that can be attributed to a lack of widespread testing, or as widespread as it is now. And so you can still see that when the decrease in cases corresponds to 2 weeks after the implementation of most of these lockdown policies, which suggests that they had an impact on the spread of COVID. And again, the scale of this, it's hard to see, but in comparison to China, where after this initial wave ended, China was able to decrease their cases to like 10 or 15 per day, whereas Italy, that it remained around like a few hundred per day, which allowed for this second wave to then happen. And you can see now, in comparison to cases to deaths, there was a big spike, a much bigger spike in deaths in March and April than recently. And this kind of shows how, despite these lockdown policies, there was some overrun of the medical system, of course, and which led to a high level of deaths. And then looking at economically. So this graph shows the actual GDP for GDP growth for the first and second quarters of 2020, and then projected for the everything after. And you can see that well, in China, they have already essentially recovered to pre-pandemic levels. Italy is only projected to do so in around mid-2021. So even though their lockdown was not as strict as China, since they weren't able to sort of eradicate the virus as well as China did, they're not yet back to sort of a normal operating of the economy and are having to go into further lockdowns with this newest wave. And so we can see that overall there's been 1.18 million cases, which is 18,000 per 1 million people, 45,000 deaths, which is 716 per 1 million people. And in the past 2 weeks, there have been over 400,000 cases, which again suggests that though the lockdowns were successful in perhaps mitigating the first wave, it hasn't prevented further waves from occurring. Again, so the curve was somewhat flattened, but it didn't eradicate the virus. And it still resulted in overwhelming of the medical system. And like China, it was implemented later than ideal and could have prevented a lot of deaths had it been implemented sooner. And so now we'll look at the United States, which of the 3 countries had perhaps the most lenient lockdown policies. The first case was on January 20th, but most restrictions were put into place mid-March. And the strictness varied widely by state, where there were some states that had no stay-at-home orders and not all businesses were closed, whereas some states there was a stay-at-home order and closure of all non-essential businesses, and schools were also closed in all states. And then there were also some implementation of travel restrictions in many states. However, these restrictions were often not enforced, and that is kind of a common theme of the United States lockdown policies, where there wasn't as much enforcement as in Italy or in China especially. And many states reopened very soon after they implemented a lockdown. They started reopening, which led to spikes in later in the summer. And so this kind of shows the variation between how like the lockdowns worked in different states. So states where there were strict lockdowns, especially in the Northeast, you can see there was almost no travel in those areas, whereas in large swaths of the country, you can see closer to normal levels of travel, which kind of shows the very wide variation in these policies and in their impact. And so here's the US curve, and you can see that again there's a sort of plateauing and slight decrease of cases associated with the lockdown policies. However, the first wave of cases never really subsided in the same way as in Italy and China, and that is kind of due to the more lax policies. And you can see that it allowed for the further surge in July, and then this current surge as well. And then again, looking at deaths, you can see that though cases looked lower, since that was due to the fact that there was less testing capability at the time. And this shows a slightly better decrease than just looking at cases, but it's still, you can see that deaths got very high and suggest an overrun of the medical system in a lot of places. And so if we look at, though, more specific locations, so a place like New York, where there was a stricter lockdown and a lot later reopening, you can see the curve is more reminiscent of the ones in China and Italy, where there was a big spike, but then a big decrease in cases that remained fairly flat for a while until recently. So yeah, it just shows the wide variation in implementation and how that affected cases. And another thing that's important to think about when looking at the United States is sort of the lack of financial support and support for citizens in these lockdowns, where you saw in China where there was like distribution of food and medical supplies. There wasn't so much government support in the United States. So you can see wealthier areas were able to decrease their movement a lot sooner than poor areas, which kind of impacts the sort of inequality in the impact of COVID on different communities. And then again, looking at the economy, there was a big dip like in the other countries, and then in the beginning and middle of 2020, but there has been a recovery, not to the point of pre-pandemic levels, and also with the threat of impending lockdowns and a tightening of restrictions, we can probably expect the economy to slow down even further. So overall, we can see the US has 11.1 million cases, which is 33,000 per 1 million people, 246,000 deaths, which is 752 per 1 million people, and has had over 1.7 million cases in the past 2 weeks, which again suggests that though lockdowns could have mitigated the first surge of cases in March, it hasn't prevented any further cases. So we can say that the lockdown in the US was the least successful of the 3 countries in mitigating the virus, but this does vary widely by regions, like we saw. And similar to the other 2 countries we looked at, it was implemented later than ideal, and had it been implemented earlier, there would be a decrease in deaths and cases. And so the biggest takeaway, I feel like, for the United States is we're now dealing with the negative economic impact of a lockdown without really reaping the benefits of a flattened curve and being able to an eradication or mitigation of the virus, which kind of shows that so like compared to China, where they had a very tight restrictions and strict lockdown, and their economy did worse initially, but since they were able to eradicate the virus essentially and go back to normal, the recovery has been a lot smoother, and which has not been the case in the United States. So.
All right, now I'm gonna talk about masking, and specifically mandatory masking, which for me is a really interesting policy because I think it's the most immediate visual impact of the virus, right? You go outside and you see people wearing masks, and yet it's very hard to track directly, like masking reduces the infection rate by this much, reduces GDP, increases GDP by this much, because it's used in conjunction with other safety measures so often. So what I'm going to do is I'm going to talk about a bunch of studies that just kind of measure the effectiveness of masking on reducing airborne particles, which carry COVID. And then I'm going to talk a little bit about where we are now in terms of different countries and different states in their masking policies. So just some basics first. This is going to seem pretty simple to all of us, but just in the interest of getting all on the same page, we're going to go over it. So why wear a mask? There are 2 reasons. There's containment, which I think we hear about more, which is obviously COVID's carried in airborne particles. And so when you speak, you release these particles, and the mask just acts as a barrier to prevent these from getting into the air. There's also the protection component, which I don't think is talked about as much, probably because the masks that we often wear aren't super good at protecting us. It's more the surgical masks and the medical grade masks that do this, because the idea is just the inverse of containment. It's that when you breathe in, it'll filter out particles. But obviously, if the mask isn't super tight fitting to your face, the air is going to get in through the little holes. And so the protection is kind of harmed in that way. And how much does it help? Again, the numbers differ a lot. There's not like a super good way of saying it reduces infection rate by this much. But overall, most studies seem to agree that it does help to an extent. But the data is really limited by experimental ethics, in that you can't get someone with COVID in a room with people without COVID and have the person wear a mask or not wear a mask, etc. Obviously, because I'd be giving a bunch of people COVID. So studies are really based on the emission of airborne particles and the mask's ability to prevent those from getting into the air. And then also retrospective studies, which say like, masking started here, cases went down by here. But again, those are pretty shaky because, again, masks are often used in conjunction with, stay-at-home orders or like social distancing. So it's hard to isolate the effect of masks themselves. But onto some studies on what the best type of mask is and what the difference is in particle emission between masks is. So here are just some pictures of different kinds. We have the N95, a respirator, which is pretty much considered the best mask on the left there. The cotton, the double layer cotton that we often see around campus, and then the bandana and the neck gaiter, which are more controversial. And if you go to the next slide here, you'll see I found the study by Fisher et al. It's published in September of 2020, and it compares the relative droplet count when speaking in a bunch of these 14 different types of masks, as well as the control of no mask. And you see the N95 there is pretty good at mitigating the droplet count, as well as the surgical mask. And even all the cotton ones are very good compared to the control of none. You also see the bandana's not too bad, but nowhere near as good as the cotton or the surgical. And then you have the neck gaiter there, which I thought was really interesting because this data point has it above the no mask control, indicating that it might actually increase the spread. I think the reasoning there is maybe the spandex, the fabric, actually disperses larger particles and makes them into a bunch of smaller particles, which are less filterable. But obviously that error bar is pretty big, so it's hard to tell. But I just thought it was interesting that it's comparable to no mask there. And then on the right, you see those spikes for droplet rate are when someone's speaking. And so with the no mask, you can pretty clearly see like someone says a word, it spikes. And even in the bandana, you can still see the clear speech pattern. But then you get into the cotton mask in orange there, and then the surgical mask is in blue. You can almost not even see it because of how good it is at keeping the droplet count and droplet rate down. But yeah, I just thought it was interesting to compare the different types of masks. And if we go on here to the next slide, here's just a visual on just the effectiveness of masks from a different study. And I thought this was interesting because it takes into account droplet particles, which are just bigger particles, as well as aerosol particles, which are the smaller than 5 micrometer particles. And you see that with the surgical mask was used here. With the surgical mask, there's a very sharp decrease in number of particles emitted. Just thought it was a good visual comparing bigger and smaller droplets. So moving on here. You guys probably remember towards the beginning of the pandemic, there was obviously a big scare and people started just buying masks like crazy, like demand far outweighed supply, and there was a shortage. So a lot of health officials were actually urging people not to buy surgical masks, disposable masks, because there weren't enough for healthcare workers. So that got me thinking, there's this question, if there's a shortage of masks, if there's only a certain amount that we can allocate to the public, is there a way in which we can allocate the masks that is optimal, that reduces the infection rate, the death rate the most? So I found this study, Warby and Chang, it's published in August of 2020. It essentially looks at different distributions of masks given different numbers of masks. It uses simulations, and then it measures them against each other. So in this graph here, we have limited surgical masks, meaning I think they're enough to cover 10% of the population, and each mask offers 50% containment. And you see these bars here for the different categories. There's a light color bar and a dark color bar for each category, and those correlate with those correspond with the light colored bars are just using the surgical mask distribution, whereas the dark bars are using the mask distribution in conjunction with universal masking, which is the public using cotton masks and homemade masks and stuff like that to cover themselves when they don't have a surgical mask. And the study found that, I only show one graph here, but it was pretty universal across all different containment levels and mask numbers, that providing to symptomatic people and elderly people with priority is the most effective way of reducing deaths. And that's because for the symptomatic people, it increases containment, meaning they spread it to less people, whereas the elderly people, it increases protection. So they're really susceptible and they don't get it as easily. Just thought it was an interesting idea to play with. I would have liked to, be able to play with different variables and stuff like that, but I'm not going to go into too much about the paper, but they do a good job of, laying out a bunch of different scenarios and seeing, they end up seeing that this provision to elderly and symptomatic people is generally a pretty good way of reducing the death count. Moving on here. So I stole this from Ayushi's colloquium talk that we watched, because I did think it was a good way of isolating the masking through the simulation. And I threw it in here to show that compared to other NPIs, it's probably not super effective, right? It might reduce the infection rate a bit, but I threw this in here to show that, there's not generally a super strong consensus in terms of how much it actually stops the spread of COVID. All these other studies are kind of looking at, aerosol particle rate and stuff like that. So yeah, I just wanted to show that it might not be a huge effect, but it also might be a small effect. So there is a point in wearing it. And there's kind of this question of, the strain on the economy and stuff like that versus the benefit you get from masking. Something that's interesting to explore. So move on here. So an effective way of implementing masking might be this risk adjusted strategy. And what is a risk adjusted strategy? It's essentially saying, like, in this situation, there's this level of risk, and this is the type of mask that you should or shouldn't wear. And it essentially is hoping to give people more freedom in what mask they wear, as well as reducing the strain on mask supply, right? Because if you don't have to wear a surgical grade mask, then maybe it's better to let the medical personnel use it, and while you wear a cloth mask, something like that. But in order for it to be effectively implemented, there really needs to be public guidelines and benefits of masking, of specific types of masks, which, especially in the US, isn't really super widespread in terms of the public's acceptance of these guidelines, which is definitely a hurdle. There's also the problem of guaranteeing sufficient supply, which is really only possible through international cooperation and the strive for this response equality, which is meaning that we want to try to give every country, regardless of economic status, an equal opportunity to respond to the pandemic, which is obviously not going to happen realistically. But it's a very interesting goal to think about, and it really kind of puts into perspective where we are globally in terms of international cooperation. So something to think about there. Next slide here. Yeah, just now I've talked about like the effectiveness of it, the studies that have been done, but just to give you guys some idea of current policy, someone in chat actually mentioned this about China. They're relaxing their policy. A lot of the major cities don't require masks anymore. But it turns out a lot of people still wear them just because, I guess, the culture there. And yeah, in Italy, we see there's still mandatory masking at all times outside of the home. And then moving on to the US in this next slide, here's a visual of state by state, where states are in masking guidelines. So the dark blue is required for general public, and then the light blues are some sort of mixture of required for certain employees or general public, etc. And the gray is like no requirement. but yeah, I just think I think masking is a pretty cool topic to explore. I'm excited for future research that really that can track better the spread of COVID in the presence of masking rather than just the containment of aerosols, stuff like that. But yeah, I think that's all I wanted to say. Drop any questions you have in the chat and I'll pass it on to Jules for contact tracing.
Yeah, so I'm going to be talking about this last policy of contact tracing. And I think one thing to keep in mind throughout this overview is about the testing rate. And we've seen kind of with the previous two policies with lockdowns and with masking, it's not really critical that the testing rate is very high. If you have a lockdown and you don't test it, the lockdown will still function as it should. And if you have masks and you're not testing, the masks will still prevent some spread. But with contact tracing, you'll notice that testing is really important. So we can go to this next slide. Is a study, as a Dutch model from July, and they make this assumption that everyone with symptoms gets tested, and that's kind of an important thing that is necessary for contact tracing, because if you don't know who has the virus and you don't know soon who has the virus, you really won't be able to trace. So this study found a few things. It found that first, naturally, the more people you trace, the better. And then the second and kind of really critical thing is that the sooner the tracing happens, the better. And so like if someone has the virus for, we can see 6 or 7 days, then tracing someone at all doesn't really do anything. And so similarly, we can see ranging from purple to green is like the fewest people getting traced compared to more people. And we can see that in the best case scenario, when people are asked to share their contacts right away, we can reduce the rate of spread, the R value, from around 1.2 at an assumed baseline to under 1. And the key with having R under 1 means that any one person that has the virus, instead of spreading it to more people than their one self, they're now spreading it to fewer than one person. And so you essentially are able to cut off the spread if you can get R under 1. So with contact tracing, the model assumes that you can. And so the next slide shows a similar trend. And just in the interest of time, I'm going to talk about, there's a third slide has a study from American scientists. And so we find a similar thing with slightly different parameters, but they come to the same conclusion. And they find that regardless of how many cases we're detecting, having more contacts traced still has these same benefits. And obviously, the more cases we can detect, the better our system will be. But regardless of these other parameters, being able to trace some amount is going to be better than nothing. So we can go to the next one just because it's getting close to 11:30. This is from a British model in June, and they talk about some of the drawbacks to tracing. So they find that with full tracing of every case that has been exposed to someone for more than 15 minutes, that each case will require 36 traces. And so that's quite expensive and time consuming, and it's pretty reliant on the system being able to handle that. They say that if you're able to do that, you can have less than 1 in 6 cases. Less than that amount will actually create more untracked infections. So with this perfect system in place, you can track a ton of infections, but you really need this big system. And so in the US, we found that there's a few problems. One, we have too many cases. And so if cases are spiking like crazy, you really don't have the ability to trace with really any system. The second is that it's taken too long to find new cases. So we saw in the very first graph that once you're at 5 or 6 days before you find a new case, then tracing is kind of pointless because they've been infected for up to 5 days and they've seen a ton of people. And then the last thing that's kind of specific to the US and is interesting is that we have a unique kind of distrust for government and authority figures. And so people have found it hard in America to contact trace because people kind of refuse to share that information with the government. And that hasn't really been a problem as much in other countries, and it's why we've seen places in some places in Asia are doing a lot better. I think Japan and South Korea have done quite a bit better, especially with contact tracing, because there's a little better of a system in place and more trust in the government. I had a next slide on sort of how policy might be related and policy might be able to be changed, but I'm going to skip it in the interest of getting to some of Garrett's slides. So I'll hand it off to you.
Hi, so I thought it would be interesting to show everyone, sort of give everyone a visual understanding of how certain policies might work. So next slide, please. So we'll be going through some simulations, and I just wanted to point out some caveats that these models might not 100% reflect realities, but I encourage everyone to sort of see the larger picture for the trends and probable causes, and sort of maybe if you're so inclined, show this to other people as well so they can start thinking about it this way. Next slide, please. So when people simulate epidemic spreads, usually we use what we call an SIR model, so susceptible, infectious, and removed. Removed in this case might mean people who might have that passed away, or people who might have gotten immunity after being infected. And there's two types. There's one that's like stochastic or deterministic, where people have researchers use equations to find out. And I'll be presenting to you some of the random simulations for you to take a look at. Next slide, please. So over here, I found this website online. It's very interesting. I would encourage all of you to go and check out and play with the models and stuff. The blue dots in this simulation are people who are healthy and susceptible. The red dots are people who are infectious, and the gray dots are people who have recovered or are removed from the simulation. Next slide, please. So we'll have a control run, and this is what the graph looks like. Again, the units of time are arbitrary, and this might not accurately 100% reflect reality, but just sort of take note of this graph. And in the next slide, all we did was actually just to double the infectious radius. So maybe this might be a society that's more sociable. This might be a society that hugs everyone, even though they have COVID. And we see that there is actually a much larger exponential growth just because of this. Whereas if we were to halve the infection rate probability, we see that the curve, the exponential curve is actually gone. What we see now is actually a much smoother curve that which brings us back to the idea of flattening the curve. And this halving the infection probability might be due to mask mandates or improved hygiene, like washing your hands and so on and so forth. Next slide, please. But the previous models that we looked at sort of have all the dots sort of walking around in a random walk. But what usually happens is in your day-to-day life, people might visit more central locations like grocery stores, like schools, and we can see that the curve growth rate is actually a lot larger in these scenarios. And this is also part of the reason why people have been criticizing, for example, the new lockdowns in France, for example, where they lock down some of the workplaces, but schools and stuff are still opening at full capacity as well. Next slide, please. So in this particular simulation, we look at communities. So this might be more pertinent, especially when Thanksgiving is coming. People might be moving from one state to another state. And we see that this sort of transfer between of people between communities actually does cause the infectious rate to go up as well. Next slide, please. So in this slide, we take a look at what quarantining does for the infections rate, and we can see that the curve is actually a lot flatter, as we would expect. However, in the real life, it's not always guaranteed that we will be able to identify everyone and isolate them immediately as soon as they show symptoms. So what might usually happen would be more like the next slide, where we will only have, sorry, could you go to the next slide, please? Yeah, where we might only be able to quarantine 40% of people. So maybe this might be due to lack of testing, this might be because of asymptomatic people, this might be because of false negatives. And we see that whereas in the previous slide, the growth was really, really gentle and shallow, and even went to zero in this, where we are able to only identify and quarantine a part of the cases, there is a much more visible curve in this scenario. So that's it from all of us. We know that it's for 12:30 and some of you have places to go, but we will stay around and entertain any questions in the chat if you have any of them.